Kartika ma'am, do you hear me? Amelia?
Hello, ma'am. Hello.
Both of you are able to hear me.
கேக்குதா ma'am?
கேக்குது.
Okay. Okay.
Sir, speaker வர வரைக்கும் I'm not allowing anyone else, sir. Very good morning to one and all. So, the Department of Periodontics SRM Dental College Ramapuram takes immense pleasure in welcoming you all for this webinar. We have with us today Dr. Farakath Khan, a specialist in the field of oral medicine and radiology. He is currently the assistant professor at Sree Mookambiga Institute of Dental Sciences, Kanyakumari. He is also the director at the DIAGNOX, an exclusive oral medicine and radiology center in Kanyakumari. He has authored a book on oral manifestations of HIV and AIDS, and he has published many articles in reputed journals. He was a former editor in JOMIDA, and he has given lectures highlighting the importance of diagnosis, imaging TMD in various platforms. He is also the member of International College of Craniomandibular Orthopedics. Today, he is going to deliver us the lecture on pediatric diagnosis, why and when. Sir, we welcome you in this forum, sir. We are very glad to have you here, sir. Over to you.
Thank you so much, Dr. Padmini.
Yes.
So I would try to share my screen. Let me know. I think you have disabled me to share the screen. Kindly enable me so that I can share the screen.
Yes, sir. You should be able to share it now.
Yeah, I will try.
Sir, are you able to do it?
Yeah, just a minute. Just a minute. Can you all see the?
Yes, sir.
Yes, sir.
Yeah. Just a minute. I hope you all can see the slides.
Yes, sir.
Yeah. So I would just start it in a minute, before which, if there is a signal issue or if my voice is breaking, you can in between stop me and inform me. Other thing, in case my signal is lost and I just go off also, I will be back again. You don't have to worry. All of you just stay here. Okay. So first of all, I would like to thank SRM Dental College, the Department of Pediatrics, HOD and other staff members, especially Dr. Shankar, for giving me this wonderful opportunity to present a webinar on the topic pediatric diagnosis. In fact, he was one who suggested this topic. So I just have to take few of my pediatric cases for this particular presentation. I am aware that the people who are listening are interns and few postgraduate students. So I have put my presentation targeting at them. And first few slides are exclusively for interns, okay, just to motivate them. And then we will go ahead with the presentation. Okay. Okay. So, dear interns, most of you would be confused right now, like what to do after internship, whether to do a post-graduation, whether to set up a clinic, a post-graduation followed by clinic, clinic followed by post-graduation, or to do something else. Like some people would be interested in acting, singing, etc. So I wanted to do post-graduation, and after completing my post-graduation, I wanted to set up a clinic. But things didn't go as I wished. I couldn't do post-graduation first, but I went ahead with setting up my clinic. Then I did post-graduation. Dentistry is one unique profession where you can have your passion like singing, dancing, etc. You can still practice them along with your dental practice. So it's a very beautiful profession. And this was my initial clinical setup. I didn't have money to start this setup. So I borrowed 1 lakh and I started this clinic with the help of just 1 lakh. So with whatever you have, you can just start up a clinic until you get a post graduation or something else. Okay. And returns after investing a clinic. There is a lot of negative publicity with respect to dentistry. Most of you would be right now demotivated by seeing all the memes in the Facebook, like there is no scope for dentistry. And recently I saw this advertisement where a dental assistant was earning 11 to 15,000, where a dentist was offering 8. In fact, dentists are getting much below less salary, like 5,000, etc. But you don't have to worry about thinking all those things. Uh, Imagine after 5 years, the dental assistant would still be earning those 11,000 to 15,000 only. Whereas a dental surgeon, if he could set up a clinical practice, he could earn much more than what we think right now. Okay. And this is the place right now I stay. After 10 years of clinical practice, I feel extremely happy that I have chosen dentistry as a profession. Okay, so initially there will be bit of ups and downs, but finally I inform all you postgraduate students as well as interns that you are in the right place. That's the dentistry, and take life as it comes. Okay, you just have to keep working hard so that everything will fall in place. Okay, moving on directly to the topic, diagnosis. Diagnosis. Okay. Mm, mm. Yeah, sorry, diagnosis. So I will not be going in depth into theory of all those things, but still diagnosis is defined as an identification of a condition, disease, or a disorder or a problem by systematic analysis of background or history, examination of signs or symptoms, evaluation of the research, and investigation of assumed or probable causes. And pediatrics is a branch of medicine that involves the medical care of infants, children, adolescents. The American Academy of Pediatrics recommends children's or people to be pediatric under the age of 21. But usually minors are required to be under pediatric care. Okay. So today I have put up few cases, just few cases highlighting the importance of diagnosis, case history, investigation, etc. Okay, so it will not be boring definitely because I have put up only cases. So kindly stay awake, and if you have any doubt, you can ask in between or you can ask at the last. Okay, so these are few aspects of case history taking. I know interns will be taking case history in perio, you'll be taking case history in prosto, oral medicine, oral surgery, pedo, and you will be bored thinking why I am taking this case history each and every time. So when you set up a practice, it's not necessary that you take a case sheet and sit in front of the patient like you're doing internship and write each and everything. Tell me your past medical history, tell me your, it's not like that. But you just have to observe the patient. You just have to get all the informations in a single shot, because in clinical practice, you'll be having very less time. And each and every step in this case history is very, very important. Okay. 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 So this is one simple case which I have put right here. He was a young patient around 7-8 years who visited our setup with a complaint of a swelling in the lower lip. So you can see a dome-shaped swelling in the inner aspect of lower lip, and it was soft and fluctuant. He gives a history of uh, biting it occasionally. And he also gives a history of traumatic bite, after which he noticed this swelling. So this is a very clear-cut case. You can just, all of you could diagnose this case. This is a very easy case. This is a case of mucocele, okay, of the lower lip of a very young child. So I just went ahead with the excision of mucocele. You can see a small incision being made. So initial days, we don't know how to operate this condition, and we will put the BP plate just onto the superficial aspect of BP plate, superficial aspect of the mucin, which will spill off, and the entire content would be ruptured. So after a bit of experience, like you as an intern, after a few years of experience, you can remove the entire mucocele in total. Okay. You can see that you would have learned it from your third year, final year. While removing the mucocele, there is one important step. That is, you are not supposed to damage the adjacent minor salivary gland, which you are seeing here, multiple small nodules. These are the adjacent minor salivary glands. So you can remove those minor salivary glands also along with the intact mucocele. Okay. This is a case of mucocele. You can see he is a very young child. Only the 6 is erupted. So he is probably 7 or 8 years of age. And whenever you see a frog like this with a big belly, what will come to your mind? It's ranula. And this is a very young patient. You look at him, he has a huge ranula in the floor of the mouth. He's not able to place his tongue properly. There is a back positioning of tongue. There is a bit of airway obstruction also because of this huge ranula. Okay, this is a case of ranula in a very young child. But you can easily diagnose this. You don't have to be an expert to diagnose this. It will be blue color. It will appear like a frog's belly. And both the cases, first case and second case, they are classic. Uh, the clinical location, the history, everything is so classic that you can make up the diagnosis very, very easily. And if you could manage these cases, you can manage, or you can, if not, you can refer him to an oral and maxillofacial surgeon. Okay. So moving on to the first little interesting case, we will see. This is a patient who was around 18 years old, who came to me with a complaint of swelling below the ear. So if you notice the area where the arrow mark is, that this is the area where he told I have swelling. You can barely appreciate any swelling. So when I palpated it, I could feel a small nodule present below the earlobe. Very small nodule. Its size was around less than 1 centimeter. Initially, I thought this could be a pre-auricular lymph node. So we thought a lymphadenitis due to a non-specific cause, maybe due to cold or etc. But we didn't want to leave it like that, because his chief complaint was this. He noticed this. He noticed a small nodule below the earlobe. And he also gave a history of weight loss. So considering that some of his family members had pulmonary tuberculosis. So non-specific multiple lymph nodes. He had a submandibular lymph node as well. We thought he could be a candidate for tuberculosis. So we went ahead with investigations, routine blood investigation. We did a MAN2 and everything was negative. We took an OPG, no dental issues. But it was very, very small lesion. We didn't want to leave this patient like that. So what did we do? So we just want to make sure that whether it's lymph node or not. So there is an easy investigation called as USG for all these head and neck swellings, especially for swellings related to parotid region and submandibular region and neck region. So we took an USG, and USG showed that this is not a lymph node. This is a small mass on the superficial lobe of parotid. That's a right parotid. So now we cannot leave this lesion because this is not a lymph node. This is definitely there is a mass. There is a mass on the superficial lobe of parotid. So any masses with respect to parotid, we definitely have to investigate it because there are chances of malignant and benign salivary gland tumors. So we went ahead with FNAC, so followed by CT and an MRI. So FNAC showed that it's a pleomorphic adenoma. It was a case of pleomorphic adenoma. Okay, so we took MRI, and MRI showed the presence of tumor which is related to the superficial lobe of parotid. You all can see this enhanced mass. Okay, you can see this enhanced mass which is related to the superficial lobe of parotid. And what did this case teach us? This case taught me that you should take time to listen to the patient's chief complaint. Many a time the patients, they come to us with these small complaints. We ignore them. We ask them to come after 6 months or after 1 year. And imagine we have asked him to come after 6 months. This patient also will ignore it. He will come after 6 years. After 6 years, the growth would have been very large, and pleomorphic adenoma is definitely not going to cause any pain or something, but it will be very mass. And there are lots of complications when you do a surgery for a pleomorphic adenoma, which is very large. We have a chance that we may end up damaging facial nerve, which could end up in facial nerve paralysis as well. And for postgraduates, you can note that USG is a very useful screening tool. USG is a very useful screening tool, especially for head and neck swellings, because it's non-invasive, it's less expensive. For 500 rupees, you can get a scan, and it can give instant results. It can be used as a screening tool before you go for a CT or a MRI, and most importantly, it doesn't have any radiation dose. Okay. And whenever I see a door and a key here, there is a comedy which is going around, like a person is being locked in the room with the key is being lost, and the members from different specialties of the dentistry would try to open the door. And what would an endodontist do? He would put a file and try to open the door. A oral surgeon would smash open the door. Orthodontist would try to put a ligature wire and open the door. Pediodontist would speak to the patient and open the door. And oral medicine would review the patient once in every 6 months, and hoping that this door would open spontaneously. Oral medicine person like me. So if you are asking the patient to come after 6 months, 6 months, whatever they are saying would be definitely true only. Okay, but we just have to go ahead, stop it, do some investigation, go ahead with some sort of diagnosis. Okay, this is a very interesting case, very nice case. This is a young female. You can see her. She came with a complaint of forwardly placed teeth. Okay, you can see there is an excess incisal show off, a short upper lip, and her medical history was normal. Apart from she gave a history that she has got recurrent headaches and recurrent sinusitis for the past 7-8 years, etc. And she has rhinitis, running nose, etc. All issues related to sinusitis. And she has visited multiple physicians, ENT surgeon. She got a diagnosis of dust allergy, etc. They were treating her on antihistamines for the past 7-8 years. So we just had that thing in mind. Okay. And we went ahead with OPG. Since she gave a history of recurrent sinusitis, so we were just keenly observing the maxillary sinus. They were slightly hazy, thinking that there is a bit of fluid accumulation there. She has an endodontically treated one for a history of fall previously. But surprisingly, we noticed radio opacity, which was related to the floor of nasal cavity in the right nasal cavity. So we all know OPG has a tendency to create lots of artifacts. So initially we thought it could be an artifact, but luckily we had the lateral cephalogram with us. But lateral ceph also confirmed the presence of that radio opacity. So we didn't want to take a chance. We went ahead and an occlusal radiograph. This is a occlusal radiograph taken with PSP plates. So it is a mirror image where the objects in the right side are being shown in the left side. Okay, you can still confirm the presence of radio opacity, but the structure of that radio opacity or the content is slightly different from OPG. Okay, that is due to the attenuation of something which is present there. So now we have a confirmation that there is something there. So we called the patient's mother. We asked her the history. What did she do? How long was she having all these sinusitis, etc.? Because we could correlate the sinusitis headache to this radio opacity. And she have a beautiful history that she noticed when this child was 3 years of age, she was playing with a small bead. Bead means a small bead from the chain. Uh, and the bead was struck in her nostrils, and she remembers that she removed the bead from the nostrils, okay, which gave us a clue that there could be probably one more bead which is struck in the nasal cavity. So we sent her to the ENT department, and the bead was in fact removed from the floor of the right nasal cavity. This is the cross specimen of the bead. Whenever there is an object being lodged in the nasal cavity due to the secretions of the nasal cavity, they tend to get calcified. Dystrophic calcification, we call it as. Okay, and this is after decalcification, and you can see the exact color of the bead. It was a blue color bead. When we showed it to her mom, she told, yeah, this is the bead which I took maybe 7-8 years back from the nostrils. And what we can learn from this case is that due importance to the history. uh, when it's a child, especially, the history of the parent is very important. And imagine this patient has been suffering from severe headache and sinusitis for the past 7-8 years, and no one has diagnosed it, because all of them, they gave an unwanted diagnosis. They thought that, okay, this is allergy, this is sinusitis. They didn't go ahead with taking a simple PNS x-ray. If the ENT would have taken a small PNS radiograph, they would have diagnosed this much earlier, and all these sufferings of this small kid for 7 years could have been avoided. Okay. So coming on to another case, this is an young child, a mother brought to her. So this, when I was doing a post graduation, I saw this case. Okay, and I remember one intern was rushing to me with a case sheet. She told, sir, I saw a case where the patient's mom tells me that the patient has got multiple missing teeth, and she has gone to many dentists, and they told that it will come in 6 months, 6 months, 6 months. It's still not coming. So I asked her, how does the child appears, and she told, child was okay, sir. How was his eyelashes? So eyelashes was bit reduced. How was his teeth appearing? The existent teeth were all cone shaped. So when you hear a history like that, all of you can give the diagnosis. It's very simple. So it is a case of hereditary ectodermal dysplasia, where you have multiple missing teeth and you have got multiple cone shaped teeth. And imagine this patient has not been diagnosed by the neonatologist or the pediatrician or multiple dentists they have come across. But as intern can diagnose this case. A fourth year student can diagnose this case, because it's clearly given in your oral pathology Schaefer that uh, hypohidrosis, hypotrichosis, and hypotonchia are the features associated with hereditary ectodermal dysplasia. So this is a classic case. And I just showed this OPG. So there are no tooth buds. This person is definitely not going to have any teeth into any tooth erupting in the future also, because there is no tooth buds. And when I showed and I explained it to the mother, she was very angry with me, because she went to multiple dentists, all told that they will come in 6 months. She was very happy. When I told that it will never come, she was not happy with me. And finally, I convinced her. I told her all the details. And these are patients where their systemic health is also important. You should explain the patient mom about the status of this patient, about the absence of multiple sweat glands to the patient, because these patients are not supposed to roam in high heat and humid environment. Okay, because of the absence of sweat glands, they can develop hyperthermia. They can be seriously affected. So all these things were affected, so that his future health is at a good level. And we did removable denture for the time being. Later probably we can think of something else. And another important thing is teeth are something which are definitely essential for the development of alveolar process. When the development, when there is no teeth, alveolar process will not be developing. So these patients will have a senile appearance, like an old patient kind of appearance will be there. All these ectodermal dysplasia kind of patients, and there are several variants of ectodermal dysplasia. You all and these is an intermediate type where you get all the features. Okay. And from this particular case, what we can learn is look the patient as a whole, not just look the teeth alone. Look for eyelashes, look for skin, and there is always a saying: the case history recording takes place. Okay, the case history takes place as soon as the patient walks into the dental department or your OP. The way by which the patient walks itself can give a lot of information about the patient. Okay, by looking just at the patient's face, you can get lots of information, and don't just look at teeth alone. And this is an adult patient, just for interesting sake I put here. This patient came with a complaint of multiple caries teeth. You just can look at this pattern of dental caries. You see decalcified areas in the cusp tip and on the gingival regions. If it is a kid, you can appreciate that it could be a rampant caries or a nursing bottle type of caries, or now they call it as early childhood caries, I guess. But she is an adult patient. She is a 40-year-old adult patient. She has got multiple decalcification, which we get decalcification or we get caries in the cervical region and incisal cusp tip for adults, mostly in case of xerostomia. Okay, so xerostomia is more common in patients who are undergoing head and neck radiotherapy. This is a patient, she is not under head and neck radiotherapy, but when we ask the history, she has got severe multiple problems with respect to her knees. She has got knee pains for which she is in treatment with an orthopedician. She has got eye issue for which she is in treatment with an ophthalmologist. She has a feeling of gravels in or sand in the eye. That's the thing we call it as sand in the eye. Now she has got xerostomia, she has got xerothalmia, she has got rheumatoid arthritis. She is in treatment with multiple persons, multiple doctors. They are treating everything separately. So it's we dental surgeons who can correlate it and who can give a clear idea that this is a case of Sjögren syndrome, secondary Sjögren syndrome. She was referred to a rheumatologist and she's doing fine. In fact, we did an allography for this patient. You can see a lot of sylectasis. Typical branchless fruit laden tree is not appreciated here, but you can see a lot of sylectasis. We did an important procedure called as labial minor salivary gland biopsy, and there were definitely lymphocytic infiltrations. Remember, labial minor salivary gland biopsy is a definitive test. It is the only test which if that test is positive, all oral component for Sjögren syndrome is positive. You don't have to actually take salivary collection, etc., etc. Okay. And this particular case gives us an information that mouth is a mirror of body. Definitely it's a mirror of body which reflects systemic diseases. Imagine with the help of or with by seeing the type or a pattern of dental caries, we could diagnose a systemic disease called as Sjögren syndrome. We are into a great profession, I believe. And this is another case. This is a patient who came with a complaint of what? Discolored fixed processes. You can 1-1, 2-1, 1-2, they are discolored. They are fixed processes being placed long time back. Okay, and he just want to remove it and replace it with the new processes because he's going to get married next month. So what I advise him for to take an IOP radiograph to check the status of the abutment teeth. But he was asking me, why doctor? Previous dentist didn't take any radiograph. So somehow we convinced him for an IOP radiograph. So why do we need radiographs here? Because whatever is there present inside is not the one which we see outside. So this is an IOP radiograph. You can see multiple radio opacity hindering the eruption of impacted 1-1. So the 1-1 is actually impacted, and no one has noticed this for all these long 21 years. Okay, and we took an OPG which again confirmed the same. And we went ahead with extraction of the impacted teeth, and we removed all small multiple radio opacities. They are called as denticles. And this is a case of compound odontome. Okay. And you may come across these cases, especially in pediatric patients, compound odontome and complex odontome. And take basic radiograph whenever necessary is something what we learned from this case. And this is a case where a patient came with a complaint of multiple caries teeth. And postgraduate students and interns, you can appreciate there is multiple radiolucency. And also you can appreciate one important finding, that the enamel of all the teeth is lost. Even the enamel of the impacted 2/8 is lost. So this is a case of hereditary enamel hypoplasia, for which they have done crowns in the anteriors. Unfortunately, we also noticed an impacted teeth in the floor of right maxillary sinus. Okay, so now we want to remove this teeth. So if we want to remove this teeth, we have to localize this teeth. So you know that there are a few beautiful techniques for localizing teeth. With 2D radiographs, we have something called a slop technique. We have got a right angle technique. Slop technique, you all know. But these techniques are useful when the teeth are close to our permanent teeth. But this teeth is located somewhere far. Okay, so we went ahead with a cone beam CT. So this is a cone beam CT image of that patient. You can see the teeth being located in the floor of right nasal cavity, not in the floor of maxillary sinus. And the crown is positioned posteriorly, root is positioned anteriorly. And these are the coronal, tangential, and axial view confirming the position of the teeth in the floor of right nasal cavity. This is the difference between 2D and 3D radiograph. Okay, so whenever you are in doubt, you just have to go for a 3D radiograph. And what is this wall? This is the most famous wall of this century. And this is a wall which is present in Pakistan. The Abbottabad compound, they call it, as where Bin Laden is hiding here. From the people's perspective, or the press people's perspective, what you see is you see a compound and you see someone is placed inside a room. That's what they know. But Obama, with the help of high resolution satellite image, he know the exact outline of whatever is there. And he know exactly where Bin Laden was staying. So that's the advantage with 3D. Before we go in for a surgical procedure, imagine we are operating the maxillary sinus and you open the maxillary sinus, there is nothing there. Then you have to search the nasal cavity. That's the importance of going for 3D when you have a doubt in the 2D radiograph. Okay. And this is a patient which I saw maybe 2 weeks back, and this was a referred patient to our oral medicine center because this patient had a complaint of spacing, and you can see all the teeth are uneven. The teeth on the left side are more supra-erupted than the teeth on the right side. You can see a small white spot. What is it? This is called as Turner's hypoplasia. Okay, Turner's hypoplasia, infection from primary teeth being transformed to the permanent teeth. Pediatric people's, this is the most important thing. Turner's hypoplasia, common in central incisors and premolars. Okay, so but you can see all the teeth on this side is supra-erupted. You can see the right labial mucosa appears erythematous when you compare it with left. Okay, and when you see the patient's face, you can see the left side is completely swollen. There is a drooping of lip on the left side. Even the region of eye is also slightly deformed. Nose is slightly deformed. Intraorally also, all these areas appears erythematous. And you will not believe, this patient's mom and this patient, they were thinking that all these things are normal for him. They thought that this is a birthmark. Okay, in fact, this is a birthmark, kind of birthmark only. But none of the general physicians, pediatricians have explained him what he has. And the dentist who have referred it to me, and he was also not aware of what this is. He was planning for fixed orthodontics, before which he needed an opinion from me. And this is a case of Sturge-Weber syndrome, where you have Port Weinstein. It is a kind of hemangioma on the involved trigeminal division or maxillary and ophthalmic division of trigeminal nerve. They have other features like seizures. They have, some people have mental retardation. He was having a normal IQ. They have a calcification of falx cerebri, etc. Okay, all these are features of Sturge-Weber syndrome. And we dental surgeons should be very careful when we deal with the affected side. For example, if you're planning for extraction on the left side maxilla, be very careful, because there is always a chance that we end up with severe uncontrolled bleeding. Okay, so these things were explained very well to the patient's mom, and they were explained that these regions should be trauma free. While he's playing or something, doing something, he shouldn't get trauma in this region. And if you could touch this region would appear warm than the right side because of the increased vasculature. Okay, so again, this is a case of Sturge-Weber syndrome. Okay. And this is the last case which I am going to present. This is again a slightly interesting case, where this patient, I treated him with fixed orthodontics 3 years back. This was his appearance at that time. Okay, came with a complaint of forwardly placed maxillary teeth. You can see that excess incisal show off, a short upper lip, short mandible, in fact, very increased overjet of more than 10 mm. So I was planning to do some sort of functional appliance. Okay, but the parent was not willing. It was a very poor patient. They don't have money. They just wanted fixed appliance. You know, these patients in rural area, you know, they come to us and they say, "Enakku muttu vechi kambi venum." That's what they say. They will not allow us to do anything. They need fixed appliance. So I thought, okay, like we will treat according to the patient's desire, and I went ahead with extraction of 2 premolars. I thought we would camouflage all the incisors back. And after 1.5 years, this is what I achieved. We just tried to pull back the teeth. And patient was very happy. Even I was happy, because we got a comparatively satisfying result, since we did a compromised treatment, very compromised treatment. In fact, we was unable to advance the mandible. But when I examined the patient as a whole, you can see what is there. You can see the forward neck posture. You can see the head being not centered into the body. You can see the long neck. And you ask the patient, he tells that he has severe headache recurrently. He has got TMJ pain. He has got sleep issues. He is not able to concentrate. And why all these things? Because we have not addressed the patient's posture. We have not addressed the patient's tongue. Instead of bringing the mandible forward, what did we do? We pull the maxilla also backward, thereby causing the tongue to further push back, thereby reducing the oxygen to a greater extent. So what happened? To compensate that, the head has come forward, and the patient has been in all sorts of issues. These are certain things we dental surgeons should look at. We definitely are not. Most of us, what we do, we just look at the patient's face, teeth. We are happy, patient is happy. The interesting thing is, no one knows that who created all these problems, because patients will be going with a headache to general physicians. They don't know that teeth can cause headache, teeth can cause sleep issues, because we dental surgeons are dealing with teeth each and every day. We do a simple root canal treatment, we do a simple restoration, we put a high point there, we make the patient end up TMJ issue, headache, neck ache, shoulder ache, back ache, and the pain will radiate till toe. And the patient will not be knowing, and we also will not be knowing, that we are the one who have caused all these issues. Patient will be going to all the persons, and they will not be any. This is a relationship between the head and the body. This line of gravity. Okay, once there is a problem in this joint, which is mostly created by we dentists as a result of our dental procedures, we will end up with all sorts of problem. That's descending problem. And once the head is not centered into the body, you will have one shoulder being higher than the other, and you will have unequal gaps between arms. You have one hip at the higher level, and sometimes some patients will have pain radiating till the toe. Some people will give a complaint of numbness in the toe, and the only cause for that numbness in the toe is the temporomandibular joint dysfunction, which we created. Okay, so that these are certain things we should keep in mind, and still there is a lot of scope for dentistry, because these things are not at all being addressed by dentists or physicians. So whoever thinks that dentistry doesn't have a scope, you can pick up these things, because we still have a lot of scope. Only thing is we have to look at the patient as a whole, not just look at the oral cavity. If you look at the oral cavity, the scope is definitely still the scope is there. Okay, okay. And alone we can do so little, together we can do so much. And with all these things, what I would like to summarize is you should look at each and every aspect of case history taking, chief complaint history, etc., 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 and imaging. Whenever needed, you should choose the right imaging technique. So once again, I would thank the Department of Pediatrics, especially my Dr. Shankar, for giving me an opportunity to present a webinar here. Hopefully, we will again meet some other day down the year with interesting topics. Thank you, Shankar, and thank you, Department of Pediatrics, interns, postgraduate students, etc. Any doubts? Welcome. We can have your questions for another 5 minutes.
Thank you, sir. That was a wonderful session. I think Dr. Shankar has few words.
Thank you, Farakath. Thank you so much for accepting the invite. Okay, I know that you have lots of class schedule, everything, and when I called you and asked for this little help, you accepted immediately. Thank you so much for this extensive session, which was very useful. We usually have a notion that oral medicine is a non-clinical subject, why we should concentrate more on that. And you proved us all wrong today by showing an extensive case report. And thank you so much once again for this extensive session. Thank you, Farakath. We hope we'll meet soon in another webinar like this.
Thank you, Shankar. Thank you.
Thank you so much, sir. Just a clarification for all the participants. We had created one more link for the session. I don't think we'll be using it now. So with this, we will end the session. Thank you so much, sir. It was a wonderful session.
Yeah, thank you.
Thank you.